This project is titled Unpacked Expertise, Difficult Mask Ventilation, Judgment Cues, and Critical Decision Making. So in terms of our introduction, first we need to understand what mask ventilation really is. So it's a very high stakes, sensitive, time sensitive, procedure that necessitates very precise, coordinated, and skilled action. It can vary significantly based on the type of patient, their anatomy, the timing that it's been since the patient has successfully had a breath of air, etc., etc. So it's non-routine, sensitive, uncommon. So that makes it a very difficult procedure to teach, and that's the most important thing to take away from that ideology. There have been some checklists, some textbooks. However, there haven't been any made specifically that we could find specifically regarding the tacit knowledge surrounding mask ventilation. And this study was designed so that we could talk to skilled providers and see what kind of decision making they use so that we could help teach this non-routine case to novice learners. This has been notorious for a very difficult case to teach students because it can happen at any time, and it's so specific on what you have to do at a specific time that the time of teaching is limited. Obviously, maintaining the airway of a patient who is dying is more important than, going step by step and slowly showing a novice learner how to go about doing it. In terms of our methodology, we focused on the critical decision method, and that was employed to elicit how experienced anesthesiologists use the environmental cues to have different actions based on the events. Our participants were CRNAs and also anesthesiologists at a large urban teaching hospital, and we selected them because they were essentially experts. They had done a minimum of 100 endotracheal intubations, and that was our definition of having enough experience to have the tacit knowledge that we were trying to describe for novice learners. We engaged in semi-structured interviews with the general anesthesia induction checklist, so we could kind of probe at their experiences, find out what kind of cues, what kind of sensations they were looking for to adjust their approach. So the strategy was designed so that it would make them remember as much as possible and simulate the environment that they were in, because we did it in an empty operating room. We used a mannequin, we used the emergency induction equipment, so it was as realistic as possible. So we had the interviews video recorded, transcribed, and then they were reviewed by an interprofessional research team so that we could understand it from any perspective, make sure not to miss anything. In terms of the results, we noted that the novice providers struggled in changing conditions, but that experience was critical. There were visual cues, there were tactile cues, things that people listened to, even smells that contributed to decisions. The validation process that we identified 46 items on a cognitive map not found previously, and then 17 were not present in textbooks, 18 that were not identified by novices. This kind of showed the importance of this kind of tacit knowledge, things that aren't written down on paper, but things that when you actually do something hands-on, you just learn to do. We felt that it was important to kind of grasp at these things specifically and write them down, help explain them, so that when we're training novices, we have better outcomes and they understand as much as possible. In terms of our conclusion, experienced anesthesiologists' tacit knowledge for mask ventilation has rich sensory details, and it's critical in making these decisions. Experienced providers' recollection of a non-routine mask ventilation is even more important because the variation between different cases is critical when a hard case comes up. Training that incorporates this knowledge that might not necessarily be written down, but now that we've elucidated from our semi-structured interviews, may accelerate the time that it takes from a novice to an expert, and we can enhance this competency and ideally reduce patient morbidity and mortality, in which is what is arguably one of the most challenging procedures to teach, period. Thank you.